Hello and thank you so much for joining us today for the webinar, Tooth Replacement in the Aesthetic Zone, which implant to choose and how to manage the lack of hard or soft tissue. It is a great pleasure to introduce to you Dr. Massimo Frosecchi, whose aim during this presentation will be to present an overview of possible treatments with heterologous soft tissue graft, and in particular of two cases of anterior area implants with a different situation of the recipient. We would like to thank Dr. Massimo for being with us today and our sponsor botiss for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Massimo at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Massimo Frosecchi.
Good afternoon, dear colleagues. Greetings from Florence, Italy. Today we will discuss about an evergreen issue, that is tooth replacement in the aesthetic area. After many years of osseointegration, this is still a challenging clinical situation because we have some peculiar factors in the aesthetic area. This is the menu of today. We will share some knowledge about aesthetic area and implants. Then we will ask ourselves a Shakespearean style question, grafting or non-grafting, because as you know, in the frontal area of the maxilla is very common to use hard tissue and soft tissue grafting. Then we will see two cases, very different one to the other one, but with very different procedure. We try to obtain the very similar outcomes at the end. And then, of course, a few words of conclusions. Let's start with the first chapter, that is just to have few information about what we really know in aesthetic area and implants. What is peculiar in this area is not only that it is very much exposed, but also because the buccal bone is composed mostly in a kind of bone that is more related to periodontal ligament and presence of teeth, and not basal bone. This bundle bone is, as I said before, very much related to teeth, very thin, and if we have problems in the perioligament, like for example a fracture of a tooth or worse, an extraction of teeth, we have a resorption in the early period, both horizontally but also vertically. So what we thought in the past, it was to use implants to prevent this resorption, but what became clear in the literature is that implants doesn't prevent this resorption. On the contrary, if we use an implant in direct contact with this buccal bone, bundle bone, we will have probably in medium and long term an aesthetic problem. So what we have to do when we treat a case in the aesthetic area is to do a pre-op analysis of the case, very deep, to understand the assessment of risk of that case, and we can have very helpful books with the ITI treatment guide and SAC classification. So before we have to have a predictability of the final outcomes of our treatment. During the surgery, we have to understand which strategy we will follow, because in some cases we will try to do all together. In other cases, we have to decide to stage the approach in different stages. For example, first grafting, then using implants, then grafting again with soft tissue, and so on. It's very mandatory, it's very important to use the comfort zone positioning for our implant. We have to put the implant really in the best position in the frontal area. And we have to ask ourselves if we have to preserve tissue or increase by grafting. This is a strategy we have to decide before. And during the prosthetical phase, we must choose which protocol, for example, immediate restoration or for example, to use more than one temporary crown, or to do in early loading or in delayed loading. And of course, we use also some materials more aesthetic, like for example, aesthetic abutment or aesthetic metal-free crowns. So these kind of treatments are usually complex, and advanced treatment is rarely possible that are quick treatments and low-cost treatments. So the ITI help the clinician with this kind of valuation before, where we can feel this kind of schedule and understand if the case is a risk for aesthetic case or is not so risky. In the SEC classification, we can see that both, even if we speak about single tooth or worse for short dental space in the frontal area, treatments are never straightforward, are advanced or complex. That it means that we need sometimes different stages, many materials, and skill and experience sometimes. So what we said before is to look for a very good placement for the implant. So according with ITI protocols, we try to stay, we need to stay at least 1.5 millimeters from the neighbor teeth. We want to maintain 2-3 millimeters of buccal bone, even if we know that this bone can resorb, because we want to prevent transparency of the implant. We want to prevent concavities and reception in time. Another important issue is how deep must be placed the implant, because how deep we can decide on many kind of factors, but we can take also as an important factor the kind of implant that we will use, because if we use a tissue level implant, we normally try to stay 2 millimeters from the gingival margin of the tooth. If we use a bone level implant, we need to stay 3 to 4 millimeters from the gingival margin. If we see this case was performed with some years ago with a bone level implant, we did an immediate restoration using a temporary screw retained crown. We use a bone level implant, and it was deep enough. In this case, it was a fresh socket implant, and we see after a few months we take an impression, we do a final ceramic restoration on that tooth, and we see after 5 years that it performs quite well. We have no bone resorption, we have no lack of soft tissue. So the case after 5 years, it's still very nice by an aesthetic point of view. We see another case did with another kind of implant, was extract the tooth, same protocol, fresh socket implant, and we put a temporary crown at the moment of the surgery. We see after a few months we can take the impression very easily, and we do a final restoration, a ceramic also in this case. And we see that after 10 years, we maintain perfectly the levels of soft tissue and the levels of bone. So aesthetic is not related in the kind of implant that we use. We only have to use the right implant for the right situation. For tissue levels, normally we don't have to put the implant too deep, but we need to have a lot of good soft tissue, and positioning of the implant is really strictly necessary. That is perfect. So when we analyze an aesthetic case, like in this case, we can add together all the knowledge in this area. For example, the first principle we can look for is if the patient discover more or less the level of the gum of the teeth of course, as more the gummy smile is present, as more difficult is the case. Another important factor is to measure everything, to measure the space of the tooth that we want to insert in the mouth, because in some cases we have to modify also the neighbor teeth to obtain aesthetic. We can also try with some mock-up. Another important factor is the biotype. We can have thin or medium or thick biotype, and also this is related to the shape of the neighbor teeth, because triangular teeth are normally associated with thin biotype. Another crucial factor is the distance between the contact point and the bone peak, because we know from the literature that if we have more than 5.5 millimeters from bone peak to contact point, papilla is not predictable. So we have to measure this is important distance. Another important distance is the distance that we can obtain to put a bone level implant, for example, 3 or 4 millimeters from the gingival margin, as we said before. Another important factor is the composition, because aesthetic is not related in osseointegration. Aesthetic is related in white aesthetic, is related to pink aesthetic, and is also related to gray aesthetic, that we could call gray aesthetic the right position of the implant, the right amount of bone to maintain this aesthetic in long term. So normally we don't just analyze the site of the implant, but we analyze the smile of the patient, because sometimes we have to work on several areas. So we will see what is the situation of the recipient bone, if we have bundled bone, if we have a stabilized bone, and if we have to graft also bone and not just the soft tissue. Another important factor, of course, if we have just horizontal resorption, or if the resorption is combined, is both horizontally and vertically. Other important factor is if it's just one tooth that is missing, or is, for example, 2 teeth, because in this second case, the situation by an aesthetic point of view is worse, really worse. So sometimes when we have to substitute more than 1 teeth, we have to modify very much the shape of teeth to ensure the closure of the spaces. So starting with more easy cases, we can say that single edentalism normally is easier. Another important factor we have to look for when we study cases is if we have good amount of bone, of course, like the presence of papilla, bone peaks. These are all factors that leads to an easy solution of the case, and also thick biotype, because when we have sharp crowns and thick soft tissue, we know that is easier to put a contact point very close to the bone peaks and obtain new papilla. When we go to more difficult cases, sometimes patients don't understand that if they have this kind of loss of lack of bone and papillas, aesthetic is very unpredictable and sometimes impossible to achieve. The same thing happens when we have perio problems, because we have bone defects between teeth, and also if we lose one tooth, one single tooth, is very difficult to obtain aesthetic. So sometimes we can also try other solutions, not implant solutions. Of course, when we have infection, when we have severe lack of bone in the bone aspect, when we have resorption, and when we have a big horizontal atrophy, even for a single element, this normally requires more complex approach. Let's see this case to make an example. This case was made in 2008. we decided to use two implants, 3.3 millimeters of diameter, were in the right position, and these are temporary crowns. And this is the moment of the final restoration with zirconia abutment and ceramic crowns. And a few days ago, the patient came back to the office because he has lost his crown. We had a discementation of the crown, and we see after 8 years, the levels of bone are completely the same, probably better than in 2008. And also the situation of the soft tissue is perfect. We have a brilliant integration of the abutment, brilliant integration of the implant. We have good diameters, but anyway, you can see that aesthetic is not perfect because there were two elements and not just one. So for a medium expectation patient, this is a good case, but if we look perfectly, this is not the kind of aesthetic that we would like to have always. So going to more problematic cases, we have big atrophy on multiple teeth that are missing. We have a big span of edentulism. We have vertical and combined defects that normally are not possible to solve with simple approaches. And sometimes, rarely, we can have the opposite situation, that we have more bone that we need. So also in these very uncommon cases, we have to make a mock-up and understand that we have to remove some bone to achieve a good aesthetic result. As I said, this is uncommon, but sometimes happens. So what we understood from this first chapter, that is, we have many differences in cases, and we have the risk of lack of bone even after removing the tooth and put an implant. Okay, so what we do since 1.5 years is to try to treat in a very easy way the posterior mandible, where normally we don't have enough stability, enough thickness of soft tissue. So we just use a slice of mucoderm under periosteal with a healing abutment, so we can use the same time of healing of the implants also for the soft tissue. And at the end of the period of healing of the implants, we have a good amount of soft tissue that remains stable in time. We can see how it started and how it is after 1 year. So this experience in the posterior mandible was very satisfying. We went on for several times. We see another case where we extract the teeth. We obtain a lack of soft tissue. We have too much mobility. So we want to replace a good situation for new teeth. So during the implant insertion, we use a double layer of mucoderm, and it's a very simple procedure that everybody can perform very easily. And we wait the normal healing time for implants, couple of months. And after this time, we see how everything is more nice, more stable, and we can start the prosthetical treatment that in this case is a ceramic bridge supported by these two Straumann implants. So we started from this situation and we moved to this bigger amount of tissue, and we finalized the case. So this experience was very satisfying, and we started to use also in frontal area in maxillary cases. So let's go to the third chapter, that is sharing two clinical cases, very different one to the other one. We will start with the first case. Is a young man, 20 years old, that have to replace a central incisor. This guy has lost the central incisor at the age of 15 for a trauma, and he didn't make any ridge preservation. So the situation now is with a severe atrophy in the buccal plate. We have also a reception of the lateral incisor, so the situation is quite difficult to treat. So when we study a case like this one, my options are normally to consider the possibility to achieve a high primary stability if we have absence of lateral forces, if we have compliance of the patient, and if we have good hard and soft tissue situation. If all these conditions are satisfied, we can look for immediate restoration. This is our first choice in good cases. When we don't have this condition, we normally use customized healing abutments, and when all the conditions are missing, we prefer to submerge and sometimes to stage the surgery. So the case was studied with ITI assessment tools of the SAC tool. So the case was both complex by a surgical and by a restorative point of view. So this is the situation. We analyze with CT scan. We see we have enough bone to ensure the stability of the implant, but we have a big concavity in the buccal aspect. So for sure we have two grafts in this case. Okay, now we are in the video. Sorry again, I don't know what's happening, but we will talk about this case and try not to lose the concentration. So in this case, we want to make a kind of flap big enough to ensure a GBR technique, because we are sure that we have to graft in this case, and we want to have a full thickness flap in the central part and also around the central incisor, but we try to do a half thickness flap in the distal side of the lateral incisor, because we want to cover a little bit the reception of the lateral incisor, even if the patient knows that we have to put some laminates at the end on the neighbor teeth, because the shape of the teeth are really not very nice, and we want to combine a good aesthetic in all the anterior region. So we do a half thickness flap in that distal side of the lateral incisor. We go with the blade, leaving some soft tissue attached to the bone. And we want to maintain the papilla of the lateral incisor distally, because we want to have a bed for the flap when we will move the flap coronally. So we gently elevate the flap, trying to keep all the periosteal tissue in the flap. We elevate, then we arrive to the place where the half thickness is in contact with the full thickness, so we have to cut to obtain a good mobility of the flap, and we go on to elevate it. After this elevation, we want to fix the central position of the implant. So we also open a little bit palatally. We want to control all the situation, also because for grafting it's very important to have a big bed for our work. Normally, when we do this kind of treatments, we do also a superficial root planing, trying to remove all the bacteria from the neighbor teeth. And we start to fix the central position of the implant, trying to maintain the comfort zone respected. And then we will start with the first drill, 2.2 millimeters, and we go as deep as necessary, controlling the inclination. Normally in these cases I use also bone expanders, because I want to try to expand the bone buccally, obtaining new bone and very high primary stability for the implant. In this case, the bone was mostly cortical tissue, so we could not move so much. So we started again with the rotary drills, trying to reach a depth of 13 millimeters to ensure the positioning, the placement of a 12 millimeters implant BLT Straumann. This is the last drill we will use, is 3.5 diameter drill. We can collect a lot of bone with this kind of drills, and we will collect this bone for using in the GBR technique at the end. So this is the moment of implant insertion, 4.1 diameter, 12 millimeters BLT. We want to place the implant in the right depth, so we have to measure. It must be 3 to 4 millimeters to the gingival margin of the neighbor teeth. So we try to measure the primary stability. We try to place the implant in the right depth. We don't have to make any compromise in this moment. So the depth must be exactly 3 or 4 millimeters from the gingival margin. So more times we measure, and we must be free in the apex. So normally we use drills more long than the measure of the implant, because we want to be free to place the implant a little bit more deep if it's necessary. So after the final placement of the implant, we measure the primary stability, that in this case was very, very high, was huge. And we control that we have all the implant in bone, but we have still a very big concavity. So as we reach a very high primary stability, we did at the moment a temporary crown, screw retained. I'm sorry, it's not very nice in this case, but it was not prepared before, and it was just an opportunity. So we decide to mobilize the flap, cutting the periosteal tissue. Normally, I prefer to cut the soft tissue in this moment and not at the end, because if we graft with biomaterials and we have a big bleeding, we can have a movement in the granulous material. So I prefer to control the bleeding in this moment where there are no materials present in the bed. We also remove epithelium from the papilla of the lateral incisor. As the tissue is very corticalized, we prefer to make some holes to obtain some bleeding from that holes, and then we will put the first layer of the autologous bone collected by the rotary drills. After this first layer, we will use a second layer or more stable material. And in this case, we used Cerebone, that is bovine hydroxylapatite. That is very important in this case because it will ensure to maintain the convex profile for long term. We need a material that is not easily to resorb, and in this case we just control the bleeding, just touching with some gauge, and we want to over contour the bone in that side, so we will put a little bit more material is necessary because we want to prevent a resorption of bone in that region. After this, we also want to protect the biomaterial and we want to obtain more volume, and this I normally do in these cases with mucoderm. I cut the mucoderm to fit in the profile of teeth, and now we just mobilize coronally the flap to maintain a good position and to protect the grafting material and the profile of the new crown. So it's a mucogingival technique of coronal movement of the flap to cover the lateral reception, to cover the biomaterials, and partially the crown of the implant. So the surgery finished quite easily. We can see with this movement coronally of the flap, we control the bleeding, and we fix everything. Must be very stable. Every time we do a GBR technique and we want to have a blood clot very stable, we need little sutures but many stitches to maintain the situation. This is the final image of this surgery, and this is what we see after 15 days. And we see how we started with a baseline, and after 4 weeks and 8 weeks we have a changing in the shape of this tissue, and after 2 months we decided to take the impression for the final restoration and for the laminates of the neighbor teeth. And so we arrived to the final situation in this case. That was quite nice. We started from here and we modified the situation, as you can see in these left and right profiles, and we started to have a good profile of the soft tissue. The second case we will see together is completely different case. We have a patient with a tooth in position, and this patient is 46 years old patient with very good health, but he see a changing in color of the tooth. We also did the risk assessment, and also this case by an ITI point of view must be considered complex. In this case, we wanted to replace the tooth with an implant with the immediate positioning of the placement of the implant at the moment of extraction. And we know from the literature that when we want to extract a tooth and put at the same moment one implant, we normally must respect the bundle bone, not to stay in direct contact with the bundle bone, and to stay with the implant deeper than the normal level, because we know that some buccal bone will resorb during the healing period. And another thing we don't want to stay in contact with the buccal plate of the tooth. Sometimes the spaces are not very little. Sometimes we can have more than 2 millimeters of spaces, and in this case we can graft with hard tissue grafting. When the space free is less than 2 millimeters, we just have to maintain the blood clot in position, and it's enough. So if we see this case of this video, this is the clinical situation. The patient is the husband of a dentist. So this dentist, the wife, she took an X-ray and something was not clear at the situation of the tooth, and we did a CT scan and we see an external resorption of the root, not too big, but we decided to extract the tooth because we had no better solution, and if we wait too much, we can risk that a spontaneous fracture keep the extraction more difficult and we can lose more bone. So we decided, according with this colleague that is the wife of the patient, to proceed to an implant solution, fresh socket implant. So we find the good position more lingually. As you can see, we preparated with the first drill in the lingual plate. We maintain the buccal bone, we control where is the level of the buccal bone, and we see that we want to stay in that position, leaving a space in the buccal aspects. So also in this case, looking to the advantages of a conical implant, we want not to go in to the buccal plate that is weak. We want to stay more lingually. So in this case, we want that our final position of the implant can be this one. And in this case, it's not very easy to achieve a very high primary stability. So normally, in these cases, I don't prepare all the length of the implant socket. I just drill 80% or less with the final drill, and we will use also in this case 12 millimeter 4.1 BLT implant. And also in this case we try to go in the right position, final position, that must be 3 to 4 millimeter deep to the gingival margin. We have these little holes in the mounter, that is, every hole is 1 millimeter, so we know that if we submerge 3 holes, we are 3 millimeters. So we use the hand driver, and we control also in this case if it's deep enough. We have a good magnification, good illumination, so we control the level of vestibular bone, and we control the position of the implant. So we decide to go deeper because it was not deep enough. And also in this case, we control the final positioning very slowly. This is a phase where we have to go and control more times, like we saw before. So we control the level, how much space, and in this case we use a temporary abutment to make an immediate restoration. We see that we fix the temporary abutment. Is very comfortable to prepare these raising abutments. We start drilling like if it's a natural tooth, and the color is very good because it's very useful for many different cases. Normally I remove a big part of this abutment, and we can use the normal composite of the office to do a very efficient temporary crown screw retained. So I like restorative dentistry, and so sometimes we spend 2 minutes more to work. Of course, we don't have the rubber dam, but it's because we can remove the crown after this. This part of work is dirty part, but we can remove the crown, we can remove some composite and put new composite at the gingival margin. So I normally, in this phase, I don't care very much about the lack of precision at the gingival margin, because I will remove it. I just want to obtain a good shape in the biggest part of tooth, but I don't care so much about the gingival margin. So we add some composite. After sometimes it's not very difficult to do. When the shape is ready and we can do a little bit more adjustment, after this primary adjustment, we remove, as I said before, the crown. So we make a hole and we descrew the crown. So we can correct the rough part that we have at the margin. You see, is not perfect at all. We have another thing to manage now, that is to fill the space between the implant and the buccal plate. So we put a closure screw just to protect the internal part of the implants. And we put some cerabone also in this case, because we want to fill this space, avoiding that some soft tissue can grow inside. And also for another reason, that if some bundle bone will resorb in time, there is this very hard shield of hard tissue that can remain inside. So we also, in this case, we have to control with magnification and good illumination not to leave too much material around that can disturb the healing of the soft tissue. So we'll maintain this material under the line of the buccal plate. We just have to feel the medium and apical parts. As I said before, as we have the crown outside the mouth, we can remove some composite, we can use new composite, and we can polish perfectly in the lab. So we will spend a few minutes more outside the mouth to obtain a very good profile and a very sharp, a very polished surface. This is mandatory in these kind of cases because the healing of soft tissue depends mostly in how clean is the surface and how polished is the surface. So we want to obtain a very good surface at the interface with soft tissue. When the situation is ready at the level, we can screw again the crown in position. We fix in a very stable way. So we want to obtain a very high stability because we don't want that during the healing we have the problem of the screwing. So we finalize the situation closing the hole. It's necessary that everything is clean, is sealed, and we just have to remember where is the position of the hole. So we do a final adjustment of the surface. We can spend a few minutes if we want to have a better aesthetic result. So we will polish, we will use all the normal thing we have in the office to obtain a good aesthetic for that case. But we have just to work in this surface because the other parts were already polished in the lab. This is the final adjustment. In this case, we didn't elevate the flap. This is a question you could do, but normally in this case, we can probe from inside, trying to understand if we have the integrity of bony wall in the vestibular aspect. This is the end of the surgery. This is the X-ray at the end of the surgery. And this is after 7 days. We can see that we have a very good integration of composite. We have a good soft tissue aspect. And so this is after 4 weeks where we can see that we can remove the crown and we can polish again and we can conclude the case. So let's go to the few words of conclusions. We saw very different cases. The take-home messages, in my opinion, are that we need to study the case in the correct way. We have to keep in mind the predictable outcome and be able to communicate to the patient this, because sometimes we need to have more procedures and sometimes outcomes can be not the best in frontal area with implants. So we need to choose the right procedure. We have many options and we have to look for the best option and be able to communicate in advance with the patient about the outcomes that we can expect. The second point is that in the all implantology today is very common to use graft material. Many years ago we just put implants in the mouth, but today I think that we have a very big attention to soft tissue mostly, but also sometimes we have to graft in the hard tissue. So aesthetic area is one of the most important for grafting. Normally at least soft tissue graft is necessary after extractions. The third point is that we want, like in this last case, prevent resorption, because when the nature gave to us all the things necessary, our goal, our mission is to prevent problems. So sometimes we use also in this case some grafting material, like this case you saw before, to prevent a possible future resorption of hard tissue. And the fourth and last point is that experience and skill is still very important in very challenging cases, especially when we have more than one tooth that is missing, or when we have combined atrophy in the recipient site. So I thank you very much for attention. I excuse myself, even if it was not my fault, for the many problems we had of connection. Probably something didn't work very well, but please excuse me for this. And I will be glad to answer to your questions. Okay, I see. I try to open one. Is it necessary to screw or suture the mucoderm? The Dr. Merav Kedar, I try to answer. I think that to suture the mucoderm is a very good way to stabilize. The key factor is stabilization. So if you feel more sure stabilizing the mucoderm with sutures, I suggest to do. We do very often. But when we have a pocket under the periostal tissue, for example, and the mucoderm is very stable in this pocket, I normally don't use sutures. Another option that I like very much is to use healing abutment to fix the mucoderm, making a hole in the mucoderm and using the healing abutment as a pin for keeping the mucoderm inside. Thank you very much for the question. I saw the second question, that is Daisoliu. I hope that my pronunciation is right. Would you prefer block bone grafting in such cases? Yeah, this is another very interesting option. I like very much bone block. Normally, I like to use autologous bone blocks, and we take from the ramus. And the biggest indication for bone blocks, in my opinion, is single implant defects or two teeth defects, not bigger than this. But the problem is that the aesthetic outcomes sometimes is not very easy to achieve. So normally I use bone blocks only when I have very severe atrophy, like when it's from palatal, when the defect is through and through, from palatal to vestibular aspect. In other cases, when I have a palatal bone sufficiently high, I prefer GBR technique, is less stressing for the patient and is quite predictable. This is my opinion. But I had very good cases also with bone blocks, especially when the defect is very deep or is through and through. I open another question of Javid Afroz. I have problem of screws loosening implant or in screw retained. Yeah, also me too. I have problem with the screws loosening. Sometimes the problem with very deep implants is that sometimes the crown, the restoration is not completely placed because there is something in bone or in soft tissue that we push and that avoid that the screw arrives at the end. So we try to use screws at the end of their length, but in some cases it's not enough. Then after 2-3 weeks something is moving, and we have panic for this, but most of cases is screw loosening. Is not something nice, but happens. So the suggestion that I give to myself and I give to you is to control that, to have enough space between the profiles of bone to allow the abutment right positioning. Yeah. Then my friend Alex Ryabov from Russia, it makes sense to use mucoderm or CTG in cases like this. Cases like it is yeah, I don't know if I understood well the questions of Dr. Ryabov. I think that mucoderm, my experience with mucoderm was incredibly good in posterior mandible, where many patients, especially old patients, they don't accept grafting from the palate. I tried to export this experience also in aesthetic area, and my after 1 year and a half, my experience is still good. But in young patients, I suggest more to use connective tissue graft, because even if it's more invasive, I think that aesthetic area, young patient, is still the best indication for connective tissue graft. So normally I suggest to use both situation. Mucoderm, for example, I use very much also for ridge preservation because it's not invasive and the epithelialization is very quick. So I obtain very good results in ridge preservation with very simple and non-invasive procedure. On the contrary, I don't feel so comfortable to use in young patients in frontal area mucoderm, even because it's not a long time that I use. I try to answer to also the questions of Mi Luong. I hope to speak well your name, sorry. Do you prefer using temporary crown over a flipper because you want better tissue adaptation for the final restoration? Yeah, that's it. I don't like removable temporary flippers. I really hate them. My policy is, if I want something fixed, I try to keep fixed from the beginning. When there are good condition, I mean that you don't have to receive lateral forces very hard, like in deep bite, for example, or I want to have patients that they have a good compliance, they don't go outside to eat something wrong. But anyway, I don't want that nothing give too much pressure on the soft tissue. So normally my choice is to use immediate restoration when I can, not in all cases. When I can't, I use customized healing abutment. So normally I use the same resin abutment you saw before, and I cut at the level of the gum. So I maintain the architectural aspect of the soft tissue with a customized healing abutment, and then I use a crown cemented to the neighbor teeth, like a Maryland bridge, for example. Another question from Alexei Ryabov. Do you think is it possible to leave mucoderm uncovered after tooth extraction and ridge preservation? Do you have any experience? Yes, of course. I do normally this procedure. I do with mucoderm a lot of things. In this webinar there was not time to show this, but for example, I use mucoderm also as a membrane for GBR, because it's safe enough to maintain the space and to separate the soft tissue from the biomaterial inside. But if for some reason I have an exposure of mucoderm in the oral environment, it doesn't happen that it resorbs, it goes away, but on the contrary, the epithelial grow on the mucoderm very fast, very easily. So my suggestion is to use mucoderm in socket in ridge preservation. I leave exposed. The important thing is not, in my opinion, to leave exposed or not, is that it's stable enough and that enters in the subperiosteal tissue for some millimeters. So normally I elevate around the socket. I elevate a little bit the periosteal tissue and I insert the mucoderm inside lingually and buccally, and we fix with some sutures. And I never had the resorption of the material. I always had a proliferation of epithelial tissue on the material. So I feel comfortable to use in many of these cases. I hope that I answered to this last question in a good way. Thanks, Alexei. It's always a pleasure. Like was a pleasure for me this experience. I'm sorry because technology is a great thing, but sometimes something fails and we don't know why. But this is the nice thing of to speak directly.
Thank you very much for sharing your lecture and your insightful information with us. We would also like to thank our sponsor for making this online course possible, and thank you to our wonderful audience for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Further questions may be submitted directly on the website on the courses page under the Ask the Expert tab. So please go ahead and submit your questions. Please be sure to visit our website. Keep an eye out for our growing schedule of online courses. Thank you again to all. Take care and goodbye.